Okay, good morning, everyone. Welcome to our third day of RMIE. We're really excited for what we have today. The morning is going to be the pancreas session. Then we're going to have the biliary session, the colon session, and esophagus and stomach. So we have a full day of organ-based systems. We're going to hold question and answer sessions until the end of each section. So please remember to keep those in mind, and we really like you to participate in that. I have a bunch of housekeeping items, so bear with me. Give me one second, make sure I get through all of them. So we'd like all of you to fill out the course evaluation so that everyone gets course credit. Remember that for the fellows, you'll get your travel grant. And then everyone else, this is helpful for us so we know how to improve in the future. We'd like you to visit the vendors, please, at all the breaks. If you get 10 stickers, you're eligible for a gift prize, but you have to be present for the raffle, which is at the end. And then again, like I said, please think of all your questions, keep them until the end of the sessions. We'd like to thank all of our supporters, especially our Diamond, Platinum, and Gold supporters, Boston, Olympus, and Cook, and all of our other supporters for all their help. Without this, the course would not be possible. Want to introduce? So Dr. Shah is going to introduce our first speaker. Thank you, guys.
So I wanted to welcome you, and to the title of our session today is the Endoscopic Innovations Evolving to Mainstream Practice, Techniques and Controversy. And wanted to introduce Dr. Heiko Pohl, and he is a professor of medicine at Dartmouth and director of endoscopy at the VA Medical Center at the Dartmouth Hitchcock Medical Center. He has agreed to enlighten us today with an inaugural lecture on sustainability and endoscopy, incorporating sustainability practices in endoscopy. Can it be cost effective? Heiko, thank you.
Well, thank you, Raj and Sachin. It's a real pleasure to be here and an honor to be invited and give this talk. So we're going to explore today whether introducing sustainable practices in endoscopy can be cost effective. I just want to share with you how it all got started. I increasingly got upset about the waste that we generate in endoscopy. So here you can see this is like during our waste audit. This is the waste we generated during one day in our advanced endoscopy room. So how many here in the audience are GI fellows? Right? How many are practicing gastroenterologists? How many are interventional endoscopists? Okay, so we have a majority of fellows here, so you are the future. You can inspire your current colleagues and future colleagues to implement changes. Right, here's a little outline. I'm going to start with a broad perspective, just briefly try to talk about sustainability. Then I'm going to highlight briefly the impact of endoscopy, and I really want to focus on practical tips with an emphasis on cost. Raj asked me earlier to leave some time for questions, so I may skip some slides that I have prepared. So let's start with a broad perspective. When we talk about sustainability, we may often associate it with global warming and the need to reduce it or halt it. In fact, the Lancet has called climate change the greatest global health threat of this century. So I was really surprised to see a few years ago when that number came out that climate change or environmental impacts not only affects health and thereby the way we provide care, but also that we contribute to global warming by providing care. 8.5% of all greenhouse gas emissions in the US are generated through the healthcare sector. Okay, but it's not just about climate change. So while climate change is really at the center of the public discourse, human activity has strained other planetary systems, from a loss in biodiversity over air pollution and to plastic pollution, and particularly plastic pollution has become more focused or in the media recently with plastics being ubiquitous, found in human tissue and been associated with diseases, including GI diseases. So just to kind of reiterate where we put our emphasis on, some spent their careers to prevent colon cancer, which the global mortality is about 1 million, but about 10 times as many people die prematurely from air pollution. So almost daily, we hear the effect of a changing climate and changing environment, floods, hurricanes, tornadoes, wildfires. I want you to take a minute and pause here for a moment and just look at these images. And then what do you feel when you see these images? So I'm just putting this little in here as an experiment because we are bombarded with news and often we hear about tragedies and then up to the next title of whatever the news cycle is. So I think it's important to pause and really understand also what it makes us feel when we see something like this. And so although we are all scientifically minded, I think our decisions are often based also on what we think is right or an emotional state. And that also is triggering or supporting our motivation, what we do. All right, let's talk about sustainable healthcare. So sustainable healthcare has been used as a term to provide a solution to mitigate the effects of a changing environment or global warming, and to build healthcare resilience, but also to reduce the effect of the healthcare system on the change on the environment. So you can define it as a capacity of health services to maintain the provision of healthcare into the future. So sustainable healthcare, if you look at the value that we currently apply to, or we traditionally apply to the value of care, it's usually measured as an outcome or quality adjusted life years per cost. It's usually like about $100,000 per quality adjusted life years gained. But if we think about sustainable value of care, it also takes into account patient populations, global health, and thinking or looking at environmental, social, and economic impacts. I'm going to skip this slide. So now let's zoom in on endoscopy. How can we transition to green endoscopy and reduce our personal or impact on the environment of what we do? So first, I'd like to highlight where we have an impact. And of course, in the center is providing endoscopy care or procedures. I also want to say that there will always be some kind of environmental cost to it. But when we have an environmental cost, we should really make those procedures count and provide as high value care as possible. So we need endoscopes, we need accessories, we need medications for sedation, but there's also the building that we are working, so infrastructure, meaning we need like heating, ventilation, air conditioning. Patients and staff have to travel. There's organizational aspects like scheduling patients, and of course there's like education, research-related activities, and then we generate waste through all of this. Those are the categories of impact that we have. And so how much waste really do we produce when we perform an endoscopy? In our own assessment, looking at 2 endoscopy units where we did an audit, the average mass or waste mass per procedure was about 2.1 kilogram per procedure generated. Most of this ended up in the landfill. 9% was recycled, and about 28% was regulated medical waste or hazardous waste. And if you scale that to the US volume and pile it up on a soccer field, you would fill 117 soccer fields 1 meter in depth with trash, or equivalent of driving equivalent of the mass of 25,000 passenger cars. So the waste that, by the way, this waste mass has been reproduced in other studies. In Europe, it's much less than the US apparently. So here's a study from Europe, and you can see on the left side the routine procedures. They generate much less waste than advanced procedures, like in ERCP, about 4 times as much than the colonoscopy and EGD. It's also interesting, the study from Germany found that if you perform a procedure in an ambulatory care center, you generate less waste, probably related to difference in handling suction fluids, like suction canisters, presence of recycling opportunities, and reusable supplies like gowns. So here are the results of carbon footprint or carbon emissions related to endoscopic procedures from our own comprehensive carbon footprint analysis performed at 3 diverse US endoscopy units. The left bar shows the average 55 kilograms of carbon footprint per procedure. And that's not really different for colonoscopy or EGD. So just for reference, a grown tree can absorb about 20 kilograms per year of carbon. So in other words, you would need to have 2.5 trees absorb carbon for a year to offset 1 endoscopic procedure. So what's somewhat striking and in a way disappointing for me is that supplies made up only 21% of this carbon footprint. Most was really related to heating, ventilation, air conditioning, 44%, then travel, 28%. So I think the mountain of trash that we see at the end of our endoscopy days is the 21%. So lots of trash, but the trash really is, a fifth of the contribution to carbon footprint. All right, the road to green endoscopy may be long and need to address different domains. We have by now several societal guidelines that will help us what those milestones could be on that way to green endoscopy, and not just green endoscopy. I want to point out the Multi-Society Strategic Plan on Environmental Sustainability that also includes GI and hepatology, our broader specialty. So with that, I'd like to look at practical tips, and particularly with respect to cost effectiveness and cost. All right, so I'm going to highlight 5 different categories of tips. But before I do that, I want to just say something about cost, because cost, whether something is cost effective, it really depends on your view. So, and who's asking. So if you're the endoscopist, we usually are driven by if something is effective. So just let's take the efficacy of clip closure after large polyp resection. There's a reduction in bleeding, post-posterior bleeding from 10% to 4%. If you are closing defects in the proximal colon, there is no significant risk reduction in the distal colon. So, of course, we're driven by doing this and say, okay, we're just going to close the right-sided lesions. Of course, endoscopists might also be driven by RVUs, and you get some RVU bump when you do clip closure. From the societal perspective, it would be, is it cost effective? And the Spanish study showed that it's only cost effective if you close lesions that have a 13% bleeding risk. So for instance, if you 2.5 centimeter polyp in the cecum that has about a 10% bleeding risk, you could clip it, would reduce it to about 3%. But if you go by the Spanish study, you shouldn't do that, because from a societal perspective, it's not cost effective. Well, from the unit's perspective, it's really in part not about just quality, but also about the financial health. And this study showed there that it's actually cost prohibitive to use clips, because the clips should be less than $100 for the endoscopy not to lose money. And the patient asks, well, if it could help me, please clip it. Of course, it shouldn't cost much more for the insurance. And they might even say, well, clip my left-sided lesions too, because there seemed to be a little effect from 7 to 5%, even is not significant. So the perspectives are vary through whatever lens you're looking at. And I'd like to kind of mostly look through the endoscopy units lens, so with respect to sustainability and cost. All right, here's tip number 1. And this is probably, and that has been advocated as the biggest impact you can do with respect to sustainability. Don't do the procedure that's not indicated or not necessary. So we know that many procedures are performed that are inappropriate, very often related to screening or surveillance, and there are just some categories in the screening surveillance areas, which we could go into detail, which I won't here. But the bottom line is, if you adhere to the current guidelines, you're actually performing green endoscopy. You're pretty, it's a sustainable practice to adhere to current guidelines because this is high quality care. And if you perform high quality care, it's okay to have some environmental cost with that. All right. Now, from the societal perspective, yes, we have overall better care, we have less cost, and we save the environment. But from the endo unit's perspective, you actually will fill your schedule too. So you probably won't see a decrease in your waste or your carbon footprint because the schedule is still full. But what might happen is you might have higher complex procedures that might drive up your RVUs, and you actually may have some benefit from that. And you improve access because the wait times might be shorter. So that's tip number one. Tip number two, consider an alternative non-invasive test of equal quality. So of course, we all love doing endoscopies, and we might feel threatened that we do less of those endoscopies, but there are several non-invasive options that are probably of similar quality. Some of those we don't know yet, but you might have seen that we're doing much less varicose screening because we now have FibroScan. And has it changed what we're doing in endoscopy yet? Not really. We have still a full schedule. So the threat of, redirecting patients to other tests probably won't affect our own volume. From a societal perspective, quality probably the same, cost decreased, environmental impact decreased. From the endo unit's perspective, it could probably go both ways. If we as a country only doing high quality procedures and do less invasive testing, we might actually need less endoscopies. But currently we have such a high demand that probably it won't change it. All right, tip number three, is there an alternative approach to how we're doing endoscopies? And there are a couple of categories. So what's our strategy? And one thing I want to highlight as an alternative strategy, and what Ken yesterday said, question dogma. So the tradition is every little polyp is being sent to pathology, but we really only do that to help assign the next surveillance interval. So we could do resect and discard using optical diagnosis, and society have supported it, but it hasn't really been implemented in the United States. It would save, based on a study from Lyndon Hernandez, $1.6 billion if you consider a 10-year colonoscopy screening program, and it would also save or reduce the carbon footprint tremendously. All right, next, what tools are we using? So for instance, margin ablation we had yesterday can be done with near-tip soft correlation. It could be done with APC or even hybrid APC. But if I use a snare that I already used for resecting a polyp, I could just use it for the ablation of the margin. If I have to pull up a new instrument, I would contribute to waste. And so the choice of your tools also will impact of the waste you generate. Now, what I'm really liking is the bougie cap. The bougie cap is a little cap that has a conic shape on top of it. It's been FDA approved, I think, a couple of years ago by now. You can actually, on the right side, you can see how the mucosa is being stretched when you pass it through a stenosis. It's clear that this bougie cap generates much less waste than a savory dilator or, let's say, a balloon. And there's unfortunately only a couple of case series out and no comparative safety or effectiveness study. And the final thing is what is essential? Should we really, for instance, do submucosal injection for everything we do because we used to do it for a long time? So question what you're doing, see if we can simplify it, think about what's essential. And I think Dr. Bindmüller talked about this yesterday, that that's a dogma that kind of used to do. Okay, next tip, choice of instruments. And this is going to be a bigger category because it's about reducing what you use in general and think about if you can reuse something. Just want to point out, we usually follow linear economy where we take out from the earth, we use it, we put it back into the earth. But resources are not finite, so at one point, we cannot do that anymore. It's pretty clear. So we have to go back, circular economy, meaning what we use has to somehow come back, not just being thrown away, but being reused, prolonged use, shared, repaired, remanufactured, recycled. So increase reusables, decrease single-use instruments. So I'm going to talk about reusable versus single-use instruments. Bottom line is you save cost, and it's the benefit increases the more often you reuse them. So the numerous studies about this showing the cost benefit. In endoscopy, we really don't have much left that's really reusable. We have savory dilator that could be reused, grasping forceps, scope valves, and we still have endoscopes that we're using, luckily. And then there are supplies that could be used, like blood pressure cuffs. Our unit transitioned briefly to disposable blood pressure cuffs, which is ridiculous. Now we're back to reusable ones. There's a lot about PPE to say. And then there's also patient items like socks and denture box that could be reused. All right. So just want to briefly touch on endoscopes. If you had the single-use endoscopes, you would increase your waste mass by 40%. So not this 2.1 kilogram per procedure, like add 40%. It's also for duodenoscopes a much higher carbon footprint, between 23 and 76-fold increase. And the upfront benefit of a decrease in infection risk is actually lowered, or it's actually less on the long-term health risks that you have from using single-use instruments. So bottom line is it's not cost-effective. It costs the end unit more, unless the single-use instruments, for the cost perspective, would be much less expensive than they currently are. All right, let's talk about what you can reduce. And there's a lot of different things that you could reduce. Doug Rex yesterday talked about using snares for every small polyp that you see, because you might see a bigger polyp later on. Clip closure, do you really need to close clips where there's no efficacy data? So if you don't close them, you of course save clips and waste. And then we talked about submucosal injection. There's an increased number of studies that suggest that SNES ulcerated polyps don't need to be submucosal injected. If you can see the margin of the lesion well, you can just resect it cold. All right. I also want to point out that in the working with your techs, in your supplies that you use, there are several options where you can reduce things. I'm not going to go into the details here. I want to point out that it's really important how you manage your inventory. So ideally, you have like endoscopy manager who knows exactly when something is being expired. So our unit was part of a large prospective study looking into expired instruments. The interesting thing is that after a median expiration time of 3 years, all were still sterile, and the ones that were tested for function, only one didn't function, which was an overtube. You can see you would save money, and of course, you would also save waste or reduce waste. What's interesting here is that it's a 3-year expiration time, or the median time to expiration is 3 years. So people sometimes say, well, industry should just extend the expiration time. But it seems even if they extend it by a year or two, we would still have an issue. And really the responsibility is probably on us to have a better management of our inventory system. And there are some pointers I could give, but in the interest of time, I'm going to skip that. So tip number 5, right trash. I think it's actually one of the easiest thing to implement, where you can do something good for the environment and decrease cost. Because we notice that a lot in the hazardous waste bin, the regulated medical waste, actually doesn't belong there. And this regulated waste, hazardous waste, needs either to be incinerated or autoclaved, so it has a higher environmental impact and costs more. So if you just make sure that this is not in that trash, but somewhere else, you already reduce cost and help the environment. So we went down from like almost 30% of trash was hazardous to less than 5%. And most of it is actually related to the suction canister effluent. So that stuff, if it's not visibly bloody, does not belong into the hazardous waste bin. Right, here's an interesting study from Italy. It's simple intervention, educating your endoscopy team, putting bins in the right place could reduce hazardous waste, emissions, and cost. All right, I want to point out that there's already some guidance material on the ASG website and also been published. So for instance, you can find more details about appropriate waste management in the series and how to green endoscopy units. The reduce part is just about to come out. I just received the proofs and we're working currently on the reuse. We're also working with the Canadian Association of Gastroenterology on sustainable indicators so that you within your unit have an idea once you accomplish certain things, whether you can say, okay, we have a sustainable practice. So hopefully that's going to come out before the end of the year. And finally, I just want to say we're not going to save the world with this. And even if you have small things that you want to, like, let's say you change from large polyp jars to small polyp jars, which is clearly a benefit for the environment, but it won't change really. It has a small impact, but it's really important to know that when you do something, you might inspire others that watch you do things. And they might ask questions. They might even say, what the hell, this doesn't mean anything. But it inspires a conversation and even questions. And this may have a ripple effect that you wouldn't maybe know what might happen. So I think wherever you are, you might inspire change. May it be in your unit, may it be in the hospital, may it be at a conference like this. So I'd like to encourage you to get started. And if you go home tomorrow or on Monday in your endoscopy unit, think about what you could do to reduce your waste. And the many things that I kind of proposed here could also save cost. So I'd like to close with this quote from Mahatma Gandhi: the difference between what we do and what we are capable of doing would suffice to solve most of the world's problems. All right, thank you. I think we have like 5 minutes for questions.
Thank you, Heiko. I was hoping that this might generate some discussion and opinion about, how we can best. One of the challenges that I've had is related to just engaging endoscopy unit staff, because some of these implementations or considerations increase work or perception of work, and also perception of what regulations really are related to sterile water versus filtered water, as you brought up for endoscope washing. And I wonder if you have advice to all of us on how you've been able to implement this and how you engaged your staff to sort of maybe show some degree of that there could be efficiency in doing some of these things.
Yeah, it's difficult, it's challenging. I think it's very important that all in your endoscopy unit know about this. So bring it up at business meetings, have leadership support, like, make sure that your leaders in your unit and even the hospital would support any efforts. Ideally, you have like green champions. You have someone in the endoscopy unit who's really carrying this forward and taking responsibility. Mostly techs or nurses know much more about all the stuff we use than we as endoscopists, and they have great ideas. So ask them what they think could change. But you have to. It's kind of a spirit change. So I work in 2 endoscopy units. In one endoscopy unit, people come to me and say, "Hey, we could do this to reduce the waste." In the other endoscopy unit, it seems like a little more challenging because it's also a little bigger and it's harder to implement changes. So, but you have to have buy-in from the entire team, and you have to listen to those people who also say, oh, this is BS, you can't do this, and more work, more costs, whatever. The other thing is you need time. You need to have some time for this. So ideally, one person should have some protected time to put attention to that. Now, if you can save costs, and there are several items I mentioned, that might be a big argument for leadership to also say, okay, we're going to give it some time. Yeah.
And Heiko, brilliant talk. I have a couple of questions, if I may. You mentioned the balance between the cost on the one side and the green endoscopy. What about the balance between quality and green endoscopy? You mentioned guidelines, high quality, that makes endoscopy green. On the other side, travel costs of patients are increasing in our country, and I'm sure here as well, because they travel to specialized centers, many, many 100 kilometers or miles. So how, if your thoughts about this problem. The next problem is not the travel cost of patient, but the shipping costs of the devices. We produce many things somewhere in the world, and they are shipped back. So these are enormous costs as well. And last point is the congresses, as you mentioned, should we do everything online to stop traveling, shipping? What is your opinion?
Okay, this is, I like those, I love those questions. So I forgot the very first one. What was it? You had four things. What was the first one? Well, anyway, let me just do the three. Oh, the quality. That's fascinating. So sustainability does not equate quality just by itself, right? For instance, one of the things that's interesting, EMR versus ESD. There is a study from the French group that says, oh, you save actually carbon footprint with ESD, with universal ESD. It's a little questionable because all had got general anesthesia and they followed the patient after R0 resection 3 years thereafter. So you can say, okay, it's great, but then we have studies that show it's not really cost effective to do universal ESD, like the Australian group. So you should do selective ESD, and that's more cost effective. So you have to be careful about keeping quality, and we want to provide high quality care, no doubt about this. So, but are there options to keep the quality high and also think about what tools are we using and how are we approaching certain situation? So that's the quality. Travel. Yeah, I mean, ideally we have public transportation, we have shared rides for patients, and that's a big aspect. It's a little less that we can control. So I would leave that aside. That's more like a public situation issue. Our own travel, same situation. Conferences, very interesting. And I applaud the ESGE activities of trying to green conferences. We actually trying to also implement some changes for DDW. There was a recent DW council meeting, which I haven't heard yet, but we proposed some green DW interventions, and we'll see what we can achieve. So that's short answers. Did I miss something? But shipping costs. Excellent. So one of the things is in your endoscopy, when you order something, two aspects. When you order something, make sure you order in bulk. It's the same as you order something through Amazon. Don't do overnight. Overnight is usually pre-airplane, and you have a much higher carbon footprint by air. So ground transportation, bulk, not urgent. You may even in your endoscopy unit combine other services, think about how you organize that. So it's number one. And we didn't really realize it. I heard this from a Cook representative telling me that's what we should do. Number two, about companies are not really open with their information, how they ship things. Of course, when something is produced in Asia, being shipped here, we don't know what stuff is being shipped per sea, which is much less carbon footprint versus air. But I know that some companies are trying to be conscientious about this and ship it per sea. I also want to say we have a joint industry ESGE project where we're trying to come up with joint statements that we understand each other better. And one of the things that I've learned, some companies are really trying to reduce their carbon footprint when manufacturing things, like having 100% solar energy in a manufacturing plant. So I think there's a lot of things that they do good, which we don't see. So we see the mountain of trash, which is terrible. You want to have like reusable instruments, but on the other hand, something's happening there too. All right, long answer. Could talk about this for another hour.
Hi, thank you for the presentation. A question on gowns. I see some GI labs use gowns and they're washed. Others use like plastic gowns, and just wondering what your practice is and what you've seen and any thoughts on that.
Yeah, it's clear that there's a cost benefit with gowns, and there's also environmental benefit with gowns. So there are very different gowns. I think you have like surgical gowns that you throw away. I saw that yesterday. It's interesting if you do, so most environmental analysis show a benefit. The interesting thing is when you do an environmental analysis, you consider that you use a gown 60 to 70 times, and then you throw it away, right? Are we only using gowns 60 times? I wouldn't think so. And so it's actually underestimating the benefit of reusable stuff. Now, of course, there's an aspect you have to use it once. You put this into a truck, The truck is going somewhere else, maybe where there's like a centralized, reprocessing, washing area. And so that's also contributes, but even taking this into account, it's a benefit. So I can only encourage you to think about reusable gowns. It's also a policy of the institution, how to do that. There's also option to recycle gowns. It's not that simple. There are some companies who do things with that, not just throwing it into the waste, to the landfill, but using it for other material. Anyway. Most cloth gowns have plastic in there, right? So what gowns are we talking about? There are different reusable gowns. They have to be repellent.
Yeah.
And so, yeah, it's cloth. It's usually a combination. There's some plastic in there and some cotton or so. There's lots to say. There's also, if you wash something that has plastic in there, you have microplastics going into the water and all that. So that's not being accounted for. All right. Thank you for letting me talk over time.
Thank you so much, Heiko. That was an excellent talk and great discussion. We're now going to kick off our pancreas session. Our first lecture is going to be given by Dr. Sumit Singla. He's Associate Professor at Michigan State University, Chief of GI at Henry Ford. We're going to be talking about evaluation and therapy for non-biliary recurrent acute pancreatitis. Welcome. Thank you.
Well, good morning, everybody. That is a very tough act to follow. I was just thanking Raj for putting me right after Heiko. So thanks again, Raj. But I do want to start by sincerely thanking the course directors, Sachin, Raj, Anna, Bilal, Christy organizing, and the whole team. You guys set the bar so high for this and so grateful to be included. I want to I do this with almost all of my talks. This is Melissa. She's a patient of mine, a patient of some of my nurses in the room. She was diagnosed with cholangiocarcinoma in the setting of PSC, ended up passing away a couple years ago. I use her as my example of how I want to thank my patients and thank our patients for allowing us to help people and to grow. They give us their trust and they deserve our gratitude as well. I want to thank and shout out my team. This is the docs at Henry Ford. ERCP, I'm saying this for the fellows because I didn't speak the fellows course, but ERCP and advanced endoscopy is a team sport. So always think about who your team is. Certainly it's easy to think about your physician colleagues. This is an old picture. I love this because I look so young. I remember when I was in your shoes and I was at this course in 2014 and think about your nurses. This is hot off the presses from just a few nights ago here with our nurses and our fellows here. So always think about the people around you. For today, this is going to be a brief and very casual clinical talk, thinking about the evaluation and management of acute and recurrent pancreatitis. I'm going to start with a clinical scenario. When I give leadership talks, one of the things I try to do is encourage silence. So I'm not going to read this out loud. I'm going to ask all of you to read the clinical scenario on your own. And I'll tell by your eyes who's not reading. And you will be called out because everybody's wearing a name tag. So not the hardest case in the world. There's not a big cognitive challenge. I find for me, I'm a simple person and it helps to think about a patient, have them in my mind as I walk through anything clinical thereafter. Here's my disclosure slide. So we were talking, Ryan and I were talking the other day about how AI tends to be everywhere and it's the solution to everybody's problems. And this is a non-endoscopic talk. And this is my own personal disclosure, is we try to find an endoscopic solution to things, and this is not going to talk about endoscopy at all. So this is real basic. How do we establish a diagnosis of pancreatitis? You guys all know this, the characteristic abdominal pain, the serum lipase 3 times the upper limit of normal, and imaging. And I want you all to commit in your minds back to our clinical scenario, and I'm looking at Heiko for the waste that could be associated with additional imaging. But really think, do you obtain a CT scan or do you not obtain a CT scan? And we'll walk through this a little bit, and we're going to lean heavily on some recent guideline papers. So when I was a fellow and resident, the thought was volume, volume, volume. And while acute resuscitation is still critically important, the amount and the timing of volume has changed in my decade of being a clinical advanced gastroenterologist. Coming back to what Ken said yesterday about challenging dogma, it's important to design studies like our waterfall study from a few years ago that tells us how much volume to give. So prior to that, it was generally looked at as more volume, the better, really flood patients even a day or two into their course. And as you guys know, that study was stopped early because of safety concerns with volume overload without any benefit. So my suggestion, my solution is to think about, and I'm going to look at this diagram now on the right, think about where your patient is along their course of acute pancreatitis. For those of us who do a lot of ERCP, I know when that injury is. And that injury is time 0 when I'm contacting the papilla. And that is a time where I can truly modify what's going to happen to my patient. But once you get to a stage, by the time a patient has pain for 24 hours, then goes to the ER and then gets admitted, you've probably missed that kind of golden window where fluid resuscitation is going to be very, very helpful. So think about your patient acutely and think about whether hypovolemia is present to guide fluid resuscitation. This comes up all the time in endo suites, and I don't know how, and I would be curious to hear from others how protocolized your endo suites are with LR versus normal saline. This is something we've struggled with as we've scaled up and gone to different hospitals, but there's clear benefit that lactated ringer is better for resuscitation than normal saline. When I start an ERCP, I always just double, triple check patients on LR as long as there's no renal contraindication. How frequently to reassess? I love telling stories about my time as a resident when we were just awake for 30 hours and we go back and see patients every 1 to 2 hours and see how they're responding to their initial fluid bolus. But when you guys are driving the ship, depending on what hospital you're at, if you're very involved in the care of acute pancreatitis, please make sure you're checking back on these patients frequently. Now I'm going to shift gears a bit and talk about some of the more common etiologies for recurrent acute pancreatitis. And my caveat is I was told this is non-biliary. So my life is a therapeutic biliary endoscopist. I'm going to put all of that on hold as much as I can and not think about gallstones. So alcohol, so silly. Take a good history. Make it safe. We talked a little bit in the fellows course and yesterday about building trust with your patients. This is another time. You want to make it safe for them to be honest with you about what they're going through. If they're not going to be honest, look at the labs. And, we're a big liver transplant center and think about a PEth test because really additional testing that's going to be down the road, none of it is cheap. And it can lead you down pathways that you don't necessarily need to be going down. This is fascinating to me how often people don't understand that cigarette smoking is an independent risk factor for acute pancreatitis. My fellows are spectacular. Our residents, our med students are always terrific. And when they're presenting a case of acute pancreatitis, I always ask, so how much does the patient smoke? And it's always surprising to me that that question hasn't been asked of the patient. So please make sure you take that really good history. And then my silly cartoon, just to remind you that the cigarette doesn't just beat up the lungs, it beats up the pancreas too. Triglycerides. I always see residents and fellows checking triglycerides. To be honest, we don't manage these patients as closely in therapeutic endoscopy, and there is good evidence that you should check triglycerides. It's not akin to rechecking a lipase every day, for example, something that has been shown to be of no benefit. When someone hits the ER and you don't have a clear etiology, there's no alcohol, there's no gallstones, very, very reasonable to check it. Be aware that 5% of all cases of acute pancreatitis can be due to hypertriglyceridemia, which is a much higher number than I would have expected. Medications. This is always something, and I'll come to the medication that really keeps us up at night, so to speak, when you think about medication-induced acute pancreatitis. This was a really nice review from a few years ago that looked very carefully at all of the evidence around medications and acute pancreatitis. And it's fascinating that we always hear, oh, there's a drug that's causing it, but there's really only 3 medications where there's RCT level evidence that this medication is causing acute pancreatitis. So even class 2 It's only case control and pharmacoepidemiologic studies. And the one that I want to highlight, because if you haven't had a patient who's on GLP-1s yet, you will. If you haven't had a patient who's had pancreatitis potentially associated with it, you will. So please develop your algorithm. Currently, there's no great evidence that says GLP-1s cause acute pancreatitis. There is some evidence, I just read a paper about this, where GLP-1s may reduce the incidence of acute pancreatitis. So there's a lot to be determined in this field. This is one, I think Ryan made a point yesterday while Raj was doing his EUS about how to approach pancreatic duct obstruction. And if there's a caliber change in the pancreatic duct, that needs to be taken extremely seriously. It is also very common that patients will present with acute pancreatitis as their presenting sign of pancreatic malignancy, or we often see patients with chronic pancreatitis whose pancreas is in that burnout phase will get admitted with recurrent acute pancreatitis. So taking that history for pancreatic cancer in particular, the history is critical. The question that I always ask to help me as a simple clinician decide cancer or benign is ask about weight loss. You can be fooled with chronic pancreatitis, but it's something to always consider. And then another thing for therapeutic endoscopists is to ensure that you have good imaging. We say EUS for anyone older than 40 without a confirmed etiology, although I would also add that with how sophisticated CT scans are, you can get a very good sense of whether someone has something concerning in their pancreas. I really like looking at surface ultrasounds. I don't know, do you guys look at these in your clinical practice? And if you don't, I'd suggest that you do. The images are up and it makes us better endosonographers. So we all have a lot of good EUS videos. Eric had a terrific presentation on EUS 101 the other day. But look at this pancreatic duct. You can very, very clearly see a stone in the pancreatic duct. And this may or may not be called by your radiologist. So definitely look at that. Here, before I even play the video, you can see a stone in the pancreatic parenchyma right there. So take a look at all of your imaging, all the tools that you have available. And then here's another surface ultrasound demonstrating a mass in the pancreas with obstruction right there. So these are really high quality ultrasound images and available to all of us in our PACS systems. All right. I wanted to talk for a minute about quote unquote idiopathic pancreatitis, because these are patients I'm looking at the people in this room and I feel like I know everybody. We've talked over the last few days and you're all going to be at experience centers. You're all going to be the experts. So what do you do when a patient has been referred to you? There's no alcohol, there's no gallstones, their gallbladder stone cold normal, no medications. So what do you do next? Well, I think number one, a rational approach is to absolutely consider an EUS. It is more sensitive than imaging, even an MRCP can go along with an MRCP. This was interesting. Repeat the ultrasound. Repeat the triglyceride level. Sometimes in the acute setting of acute pancreatitis, you may have an acute phase reactant, especially at the triglyceride level. So very reasonable to repeat that. I did not talk much about genetics in this case. At this point in the patient's clinical story, very reasonable to consider a diagnosis of hereditary pancreatitis. For the fellows who are going to be going through their boards, you're going to need to know the inheritance of all of these that will be tested, but be aware of these. For clinicians, be careful of these. Often inherited or hereditary pancreatitis is given as an etiology, but there's actually a much better etiology that hasn't been elucidated fully, such as alcohol use. So be very careful. The patients that I would consider this on are those under than 35 without a really good other etiology. And then this is always something, again, this was not the case when I was training, but consider lap chole even after a single episode. In a study that I looked at, you would need to remove 5 normal gallbladders to help one person. So very, very reasonable to consider a lap chole even after one episode of unexplained acute pancreatitis. So I'm going to come back in my last minute and go through the clinical scenario again, and I'm going to ask for a show of hands. So everybody ready to tell me if they've committed to whether they would get a CT scan or not. So who wants to get a CT scan? Very few people. Who does not want to get a CT scan? Okay, I'm going to try this again. So who wants to get a CT scan? All right, who does not want to get a CT scan? All right, the vast majority do not. I actually disagree. And I feel like I didn't do a great job of confirming this or of teaching you this point. So perhaps it was how I framed the question. You don't need a CT scan to look for severity. You have the diagnosis. But this is her third episode in the last few years. And could there be a cancer present? So I would consider a CT scan in this situation. I would definitely get a triglyceride level. I would consider an outpatient EUS. And if this is the case, third such episode in the last few years, I would definitely obtain a cholecystectomy if no other cause is found. All right, well, this was my quick and clinical talk. I wanted you guys to understand the basics of acute management. I want you to think about the etiology and understand targeted management. Be very careful in ascribing an etiology unless there's a clear smoking gun. And then come back to that gallstones and microlithiasis, gallbladder sludge can very commonly be the etiology in a lot of people. And then my very last slide is a thank you and a shameless promotion of our new endoscopy unit. If you guys ever have the chance, you're ever in Michigan, please come visit us. It's a spectacular place and we would love to host you. So thank you again.
Great talk. Thank you so much, Summit. Okay, our second talk is by Dr. Hiro Isayama, who's coming to us all the way from Tokyo. He's going to be talking to us about pancreatitis-related fluid collections and leaks. Welcome.
Good morning, everyone. So thank you very much for the country introduction, Anna. So I'm very happy to be here to join this incredible course. I want to special thanks to Raju for your kind invitation. So before coming to Colorado, so I have a very good image on this Colorado because we have superstars in this area is there, Raj sure. And the other superstars for me is Peter Forsberg, so the Colorado Avalanche. So we are very I like the Peter Forsberg and our team uniform. So mimicking to the Colorado Avalanche. So then I have a very good image previously, but after joining this special course, my image improved much. So this slide is I want to introduction is my recent work, the proposal of the classification and the terminology of the interventional EUS. So this article just published in this year. So I'm the chair of the subcommittee of this activity. We classified the interventional into 5. First category is the ES guided sampling. So including tissue acquisition, sampling, fluid sampling. Next column is ES guided through the needle examination. So TTNB, so through the needle biopsy or measurement of the portal vein pressure. Third one is the ESDA, drainage and anastomosis. And the fourth one, transeschal procedure, ESCR. What is the ESCR? ESCR, we propose this word and graphically created route. So I will mention that later. And the US guided delivery, including the many procedures, US guided ethanol injection, ablation, many delivery power or drugs. ESDA has 3 categories. First one is a drainage and anastomosis of organ, biliary, pancreatic duct, gallbladder. So the aim of this procedure is a drainage, but procedure is an anastomosis procedure. So then this procedure name has a STOMI. But the second column, drainage of the acquired fluid collection, should cyst, wound, abscess. This one is disappeared after the successful drainage. So then we avoid to use anastomosis, only drainage. So then transgastric ESPFD for one or should cyst. This is our proposal terminology. Third column is anastomosis of the digest tract. ES-guided GS, GJS. So these are not a drainage procedure, but anastomosis procedure. So these are a similar procedure, including in this category, ESDA. ESCR. ESCR is a general term. Can use the just after the puncture and established matured root or cavity of the placed TDAS through the Axios procedure, also including in a trans-escar procedure. And US anastomosis procedure, we can use anastomosis or tract of this root. But ES drainage for the acquired fluid, we cannot use anastomosis, but tract. And in our literature, so I strongly recommend do not use fistula. Fistula is unintentional and sometimes not inconvenient communication. But anastomosis tract intentionally we created. So then I ask to you, please do not use fistula, use anastomosis route or ESCR generally. This is the most representable procedure of the trans-escar. So necrosectomy or recently the edge. So these are trans-escar procedures. So other proposal about terminology is a TDAS. TDAS is a transluminal drainage anastomosis stent. So we can use a stent, but a conventional stent, the aim is keeping the luminal patency and the place at the papilla or stricture. But a TDAS, keeping a ESCR, placement at the ESCR, so procedure and aim is totally different. So then TDAS required so other function. So then we propose a new category of the stent, TDAS. TDAS including the axials, other types of lamps, or dedicated tubular type stent. These are included in TDAS. Okay, back to the fluid collection. So revised Atlantic classification classified peripancreatic fluid collection into two, pancreatic pseudocyst and a word of necrosis. These are related with pancreatitis. But actually, we have a case, the pseudocyst and a pancreatic leakage. So indication of the intervention is a symptomatic under a continuous increasing case. So we performed some procedure. And the management way is to double drainage, fluid drainage, and ductal drainage we required. This is our case. After placement of the biliary metal stent, so huge pseudocyst occurred. We placed two axials, and through the axials, many plastic stent, and finally we performed the ESPDDA, and many procedure required. So, but mainly fluid drainage and ductal drainage we required. I want to introduce our group. Name is, wonderful group. So this is a focus on the peripancreatic fluid collection, and 11 referral centers joined this consortium. So I'm a little bit senior, then I'm an advisor. The president of the Yosuke Nakai, now he's a professor of the Tokyo Uma Medical University. Now, from our group, for the pancreatic pseudocyst, we presented a 1-2 randomized control trial. So this trial comparing the plastic stent versus a lumen apologic metal stent. Primary endpoint. So plastic stent showed non-inferiority to the LAMPS group in the terms of the clinical success. and the time to clinical success is almost similar. And other secondary endpoints, so clinical success, time to success, these are almost same. So then this is our conclusion. 1.02 trial demonstrated the non-inferiority of the plastic stent to LAMS. So then there are many similar RCT there. But from my personal opinion, so placement of the axios is very safe, very simple. We have many young staff. So for them, so the axios is better. Our veteran can enjoy the step by step, each step we can enjoy, but young doctors cannot. So then still, LAMS is a mainstay in the institution. Move to the WOM. This slide shows the surgical necrosectomy for WOM. So surgical necrosectomy and place many drain and do not close the abdomen. So every day, so washing the abdominal cavity in the ICU. Very terrible procedure. But recently, we can perform the endoscopic procedure for the WOM. This is 10 years ago, our Asian group published this Asian consensus statement. So this is a member of the authors. So from USA, Peter Dragoff joined. And also Lakatakia Sandeep joined. So this is a TCAP. TCAP is I'm organizer, Asian Interventional Endoscopy Group. At that time, we proposed this algorithm. So drainage and not effective case, go to an necrosectomy, not effective case, go to surgery. Step-up approach recommended. But after this statement, many new procedure published. Multiple gateway technique, multiple plastic stent placement from the one hole. This is so only one hole, but place many stent. So the many so small rooms with dead spaces we should drain, and also Parkinson's procedure as well. The wall located in pelvic cavity. So this is a recent algorithm. Not only drainage, but irrigation, multiple gateway technique, plus many plastic stent insertion, not effective trans-esca procedure, necrosectomy, not effective case, only go to the surgery. So there are many study published. So from our group, many article published. This is just published proof from the GIE. So they selected 10 top paper about US guided transluminal intervention in 2025. So 2 paper rank in from a wonderful group. We are very happy. I want to introduce some paper from our team. So 3D volume of the WOM. So and time to clinical success is different according to the volume of the WOM. It is also a very good analysis result we think. And the other one is so we analyze the step-up approach cases, and some cases required necrosectomy. Some cases don't require no necrosectomy. But the time to clinical success, so necrosectomy group is also earlier. So then we conducted RCT, compare the step approach group versus a direct necrosectomy group. Of course, current standard strategy is a step up approach, but from our result, so direct immediate endoscopy group showed a shorter time to clinical course. So we should discuss about detail from now, but it is a very important message for the interventional endoscopist. And this is another retrospective study using the Japanese DPC data. So after introduction of the lamps, so bleeding case increased and the total cost increased. It's not only related with the lamps, but it is one factor. Of course, the lamps have many complications related. So misdisplacement and buried syndrome and bleeding. This is our case. So misdeployment case. Please see the actions. So do not bring back insufficient lamps. So moving in the abdominal cavity. So I took over this procedure and place another actions. And we performed the trans-escal procedure through the lamps and with the viewing scope. So successfully retrieved the misdeployment lamps. And of course, the complication related with the endoscopic necrosectomy. So bleeding, air embolism, perforation. So bleeding, two types. The injury of wall, injury of the vessels. Injury of the vessels require the IR, so embolization. So to avoid the air embolization, we should use the CO2 insufflation. And perforation, careful manipulation required. This is the final slide, take-home message for me. So PPC and the leakage, double drainage is required. So fluid drainage and the ductal drainage, and the lumps and the PS almost equal. But I think the lumps is also still mainstay. And the pancreatic drainage, transpapillary stenting, and the ESPGS living. One, lumps is standard. This is a new evidence. Direct necrosectomy better than the step-up approach. But be careful of the complications. Lumps related with lumps, related with the necrosectomy procedure. We should perform the very careful procedures. Thank you very much for your kind attention.
Thank you so much, Hiro. That was an excellent talk. We'll invite you to come up here with the rest of the panel. And then I'd like Dr. Eric Montmany to step up. We're going to talk about painful main pancreatic duct stones, pancreatoscopy, as well as surgery.
I'm back. Nice to see everyone. Just want to say thank you again for everything and trusting me with this talk to do it in front of Dr. Deloy, Dr. Wani, Dr. Shaw. It's just surreal today. So taking this all in today for all the trainees. So I have no disclosures. Here's some objectives for CME purposes, but today we're going to be talking about pancreatic duct stones. And when I'm thinking about them, I throw them into two main buckets, and that's symptomatic ones and incidental ones. But today we're going to be talking about the symptomatic ones, okay? So when I then find a symptomatic stone, I also further kind of simplify it down. Am I dealing with a parenchymal stone or an intraductal stone? And so parenchymal stones, I like to think of putting those more into the hands of our surgeons. So individuals like Dr. Knoll and his colleagues, and kind of having the discussion if they want to even treat these at all. But if we're in the intraductal portion, that's where we start talking about endoscopic options and all the other multiple options we may approach this with. So I like always kind of breaking down pathophysiology to the most basic level. And so I ask myself, why do pancreatic duct stones form? And unfortunately, it comes back to chemistry class. You just those painful days of chemistry class. So when you get pancreatic disease, you actually get decreases in the amount of bicarb production that the pancreas makes. And what happens? You shift those acid-base equations. And so bicarb base drops, so you get more of an acidic environment, and so often calcium carbonate will start precipitating out within the ductal spaces. Other things, though, can occur, though. So you can get obstructions, just like in the bile duct. So stricture can cause stagnant flow, and that will precipitate stone formation. And it's not just calcium that we need to think of. I think often we see those pretty pictures of x-rays where we see, or CTs where you see calcium just caking all of the pancreas, but you can get protein like deposit stones as well that will accumulate and cause obstruction. On the rare side, you'll get more of a disease process that's going on. So like a hypercalcemic condition. I think of like your parathyroid conditions, your MENs, things that would put you in, or a neoplastic state, a paraneoplastic state, excuse me, where you have high levels of calcium that will then precipitate stones out. What's important, though, when we're going through stone discussions is remembering that just like biliary stones, pancreatic stones may be a symptom of something, not necessarily just the origin of a disease. So always looking at the forest and not the trees. So your first question really should be, what is the source of the injury? Is there some underlying cancer? Is there a stricture there that's making stagnant flow, et cetera? So always taking the time to ask yourself that question before you start just rushing into what you want to do with it. So for today's purposes, I'm going to try to sprint through everything so we can get through all these awesome talks today. But we have 3 silos that we talk about: pancreatoscopy, S-well or extracorporeal shockwave lithotripsy, and surgery. And they really shouldn't be silos. This should be a blended kind of discussion of what you should do, because often this is a complicated disease process and requires a complex or I like to think a family approach to treatment of this. And so whatever color orange, green, and red makes, that's what this should really be for your approach. But I put those 3 options on like a foundation of ERCP and EUS, because often where you start going down one of those roads really is from a foundation of a quality ERCP finding or a quality EUS finding. I will say a lot of surgery decisions on how to manage pancreatic duct stones are starting to pick up a lot more imaging, and they'll make their decisions based off that as well. So quality imaging, whether that be from our radiology friends or us in interventional endoscopy from ERCP or EUS, will often decide which routes you start to go, or some blended approach of this. So pancreatoscopy is one of the first topics we'll talk about. Obviously, we've seen a lot of it. It was beautifully done yesterday. But essentially, that's just the utilization of direct visualization in the pancreatic duct via ERCP. So you get your wire into the pancreatic duct, you pass your pancreatoscope into the duct, and you can identify and intervene on any type of obstructing lesion, whether it just be a stone, a stricture. You can then sample masses, you can evaluate main duct IPMNs. You can actually even see some side branches developing. It's a very highly technical procedure. This is your A team that's going in your unit to do this procedure. It's a very delicate procedure. You want to make sure that you're not, accidentally injuring the duct or side branches. You really require a lot of competency in pancreatic endotherapy. And why is that? It's because of, I bring this always up with a lot of talks, is that there is Murphy's Law. Anything that can happen will happen. And when you are in those scenarios where you can cause an injury to something so delicate as the main pancreatic duct, I like to say, you need Newton's third law of endoscopy. You need to not only to be able to do something you intended, but the equal and opposite when you get into trouble. So being able to get yourself out of a sticky situation like that, where you know how to handle pancreatic endotherapy and fix an injury to the pancreatic duct. What's important to know about pancreatoscopy is you really need to be able to access the stone or stricture. So sometimes when you're dealing with lesions in the tail, you may not have the caliber to reach it. So the opposite end of the pancreatic duct is also critical, because you may have a little bit less stability near the ampulla, and it may mean that your pancreatic or your pancreatoscope is a little bit unstable. And Raj did a beautiful case yesterday where he actually was able to stabilize the pancreatoscope actually pretty distally. So that's, you know, in a pioneer like Raj who's been doing this for years, you know, for me, that's difficult. So, but your tool sets, what we'll talk about in a second, you know, when you're talking about stones, you're really leaning on things like EHL or laser fragmentation, but also mechanical lithotripsy. So pancreatic, our tool set, just to go a little bit deeper, I really love laser. I think it's really becoming more and more of a kind of the go-to thing to treat stones. I feel like it's very promising and effective. But it can also, why I like it is because you can double it up for treating anything that's obstructing your ability to get to the stone. So they've been able to develop soft tissue settings on with these laser processors and be able to actually dissect soft tissue so that you can then advance to get to the stone that may be upstream of you. Downside is it is expensive. Dr. Fan gave a great talk about you know, this earlier, and on her slide she talked about the thousands of dollars that kind of your unit has to invest in. It does require an additional layer of protection, particularly with your vision and power requirements. So if you're you know, if you're pressing your button and your lights in your unit go out, so you really want to make sure that you're up to date on all your power requirements. Just to kind of go a little bit deeper on the right side, I made this little schematic of what really is going on with laser. So you have a holmium fiber. It emits a wavelength, and that wavelength carries an energy, and it gets absorbed into the stone. And the first law of thermodynamics applies here. And so energy gets transferred into the stone, heat generates, and the chemical bonds within the calcium carbonate stones start to fracture, and you get fragmentation. So that's really what's going on. You can do EHL, it's just harder. I feel like EHL is nice for your biliary stones, and that's just because I feel calcium bilirubinate or bilirubinate stones, excuse me, are just a little bit softer and they're easier to fracture. But it can be effective. It's just sometimes a little bit harder. It does, you know, with EHL require a lot of saline and to be injected into the duct, so there is that possible risk of flooding, you know, the ductal system and causing pancreatitis. So something to keep in mind. Mechanical lithotripsy is also something we can use, not so much in the crushing baskets, but extracting baskets within the pancreatoscope. It's just less often utilized. It's a tight space. It's sometimes very hard to get around the stones as it is compared to the bile duct where it's bigger. I like using mechanical lithotripsy is once I've had the fracturing, it's just a little bit easier. You know, I can see and get some of these, you know, the fragments in the basket. So proprietal device right now is like a spy basket. So you can use that once you have some more fragments. I'm going to play this video again. And for the fellows in the room, we keep playing this video because, you know, this is done by Dr. Shaw, and he's not only charming, he's also, you know, like the Michael Jordan of this field. LeBron James, sorry, Raj, sorry. I know he's a big, sorry. But it's, you know, you should really take this in while you're here. So you can see this is Dr. Shaw, you know, demonstrating what I was talking about with dissecting out a stricture. So using soft tissue settings on laser in order to then make his way then to a stone. So this is why I think laser is great. So you can see he has the soft tissue settings, and he has this beautiful stricturotomy that he does. And you actually start seeing it split. And that's an awesome view. You can actually see the stone. Raj then comes back later on a different day, and you can see now he's starting to fragment the pancreatic duct stones and clear the duct. And so now he's been able to use that stricturotomy to access this big stone and just dissolve the stone, and now he has clearance of his duct. It's beautifully done. Changing gears, we're going to talk a little bit about S-wall, and then I like to Think of that as I have to, walk down the hall to the urology department. And the objective is very similar. You have to fracture a large stone to make it into smaller fragments so they can either spontaneously pass or you can use ERCP to extract them. For kind of big picture, you really should be using this for larger stones because you really have to be able to see the stone. And it is a really good resource if in the, you failed ERCP, and particularly when they're further down the duct, by the tail. Some limitations do occur with this, and sometimes I think we get really caught up in the nitty-gritty of limitations, but the biggest one I feel with SWAL is communication. And I think that it's fundamental when you talk to a patient, you're having them come to you for a pancreas problem, and you're sending them to a bladder department. And I don't know if you've had any patients who are like, you're sending me to something that doesn't make any sense. I'm canceling that appointment. I don't know why you sent me there. So communication is key, not only with your patient, but also between team members. And so I think it's easy for people, to get confused in the hospital system, especially patients with something so complex as chronic pancreatitis and all the pancreatic stone complications that come with that. So really being able to communicate is key. You really need the right patient. So this is on the nitty-gritty end of it. So you can't have like any overlying lung or any type of calcified vessels. Anticoagulation can be an issue. So it's a little bit better now with DOACs and being able to hold that, and guidelines have gotten better with holding anticoagulation, but it is an issue. It will not address any underlying stricture. I'll show you that in a second, but you need to make sure you're not dealing with any strictures first, and you may need to treat those up front. And it will require often a couple sessions. It's usually less than 3, but it's not a one and done per se. And like I said, you need to be able to visualize the stone. It's also not a one size fits all. And if there's anything you guys take from my talk is that, again, this is not a electric circuit box. You don't flip one switch and that's the right light switch. It's a kind of a spectrum of what approach you'll take. And sometimes it's okay to switch. You may do a little bit of SWAL, help you, maybe some pancreatoscopy to help you. It can be a little bit of a blended approach. With SWAL, like here's a nice example. You can see this pancreatic stent is in place, and it's treating the underlying stricture. They're targeting and they're fracturing. You can get a phenomenon, and I'm going to, Dr. Mesbin, you can check my German. This is Steinstrasse. It means Stone Street. I don't know if I said that right, but it's essentially the importance of treating a strictures, because you can fragment a big stone, and this can happen. You can get essentially a piling up of small little fragments. This is actually in a ureter, but it was such a beautiful example, I really wanted to use it. But you can get a really big piling up of a big fragment that progresses into a bunch of small, now obstructing fragments. So again, just making sure you're keeping track of all that kind of collective approaches you may have to take to get these stones out. Surgery, it is the most invasive part of what we do. And the approach really depends on where disease is and what's your goal. There's a palably of options, and it depends on what the pancreas looks like, what the patient's expectations are. I think most often we see pistos, or what we see where we see a diffuse duct, and the objective is really ductal decompression, help with pain, getting any type of obstruction out. But you could have anything from just taking out the distal pancreatic gland, or you have to do something big like a total pancreatectomy. So it's really going to become a discussion and what they find in their evaluations. But it does come with all the risks of surgery as well. So it's a key that you find the right candidate for this. But you can have things like fistulas, leaks, infection, reintervention with surgery as well. I wanted to quickly mention, the discussion of if surgery is better. And, the big thing that came out was the ESCAPE trial with this. And the lower, I don't know if you guys can see down here, this was the big finding from the ESCAPE trial. We saw pretty much a continued response when they did surgery up front with improved pain scores in these patients compared to endotherapy. And you have to give credit where credit's due there. So these were people who just had really good surgical candidacy. They had dedicated pancreatic surgeons for most of these patients, and patient expectations were good. So all the stars did align and showed that early upfront surgery was a good option for pain management. I do think they came with an update last year and they kind of tried to spike the football with this escape. And they said, they called them one day and called them again and asked them how their pain was. And a lot of the surgical groups said I was still doing better compared to the endoscopic approaches. And if anyone in this room has treated chronic pancreatic or chronic pancreatitis patients, you call them on a good day, their disease is great. You call them on a bad day, their life is just like nothing worked. I'm so pissed. I underwent this big therapy, and so this was one day I want you to know about. They just called them. And it wasn't like a continued measurement. It was just one day they called and they reassessed all their endpoints. What's really important, I think you have to look at is some of the secondary endpoints compared to surgery, which is what I highlight right here. And it's kind of scary stuff that, some of the major complications of chronic pancreatitis were not different between the two groups. So even though they had surgery, they still had organ complications. So with pseudocysts were the same. Chronic opioid use was still the same. And flare-ups were all the same, and number of flare-ups were no different. It's not high amounts, but still no statistical differences between those. So, when you're looking at these big trials, make sure you're kind of getting to some of the weeds with this stuff. So when I'm talking about endoscopic approaches, I like to first ask myself, one, where the stone is, and do I need to do anything else? So on the stone side, I look at where's the stone? Is it close to the ampulla or far from the, close to the papilla or far from the papilla? If it's really close to the papilla, I'm gonna kind of go to the extremes of just conventional ERCP. I'm going to try to dilate plenty, try to get the stone out. And a lot of the times you're going to be able to just do that. And that really comes down to what I think we were discussing yesterday and what I was saying earlier is that you can have difficulty with stabilizing the direct visualization and falling out. And then you're, having difficulty with stabilizing your device. So I always tell fellows, stable scope, stable device. So, sometimes conventional ERCP, when it's really close to the ampulla, is the way to go. You're going to be able to minimize your complications. If it's further away, and I'm in the neck or the body, I like doing pancreatoscopy. And if my conventional ERCP has failed, because I do have that stability, and then I can use any device I need. Do I need to do anything else? These aren't mutually exclusive. So, do I need to treat any focal strictures, and do I need to look for any type of underlying disease within the duct as far as something that's pre-malignant or already at malignancy? So that's where you may want to do pancreatoscopy. To wrap everything up, I made this super complex algorithm, okay? But I'm going to break this down really nicely, okay? So don't look at this. This is what goes in my head, so this is why I'm on. This is what tells you why it's so cumbersome sometimes. So first thing, are you going to pass the surgery sniff test? So is malignancy suspected? Again, asking yourself, what's the source of these stones? Is the patient a good candidate? And what's the patient's preferences, okay? Candidacy can go into where the stone is, right? Am I going to be sending someone for a 5 millimeter ductal stone right at the ampulla for surgery? Probably not. That's, you have to kind of take into consideration what good candidacy is. If any of those, though, are yes, I think it's worthwhile just having them have a consultation with the surgeon. If all of those, though, are no, you're going to start heading over to this end where we're talking about our ERCPs. So first part, are you dealing with significant strictures? Stents and stricturotomy may, with pancreatitis, plus or minus pancreatitis, may be a really good option there to help create room and get these stones out. SWAL also might be a good option if you're really, if you treated all the strictures and the stones are pretty far up. Are the stones close to the pancreatic orifice? Really just go for it with your conventional ERCP. Try attempting, balloon dilation, making some room for the pancreatic orifice to be open, and getting the stone out with just simple extraction. A lot of times you'll be able to do that. And then are you dealing with big stones with not much stricturing? I think it's carte blanche a little bit, as long as the stone's not really packed in the distal duct where you're in the tail and you can't reach it. So SWAL may be a great option in that case. So again, I think just simplifying this down, and it can make things of this a little bit easier. So my key points, though, is this is a complicated disease, and you should strive to really have this addressed at a multidisciplinary approach with experienced providers. This, whatever approach you take or what blended approach you take, really is a foundation of having that baseline good ERCP and EUS or imaging, because it will help you guide you which way you want to go. Surgical approaches really should be respected in this case because they do have good outcomes, but should not be disregarding endoscopy just because of, you think, oh, it's pain that I'm just focusing on, but we really need to kind of take everything into consideration. Pancreatoscopy has plenty of applications now, and it seems to be rapidly expanding. SPAL is a great option. Remember, just like surgery, you need good candidacy, and remember your location, size, all that stuff with the stone, characteristics can help you decide what you want, but sometimes all approaches are great. Here's my references. Thank you. I think I'm way over.
Thank you, Eric. That was great. Please come have a seat with us on the panel. Next, we're going to move to our really exciting debate. Pancreatic cysts, as we know, are everywhere. So we're going to be discussing continuing surveillance versus early resection. And first, we have Dr. Jennifer Fan coming to us from the Hoag Medical Center, where she is the medical director of advanced endoscopy. She's also the director of bariatric endoscopy and program director for the Advanced Endoscopy Fellowship. So welcome, Jen.
Thank you. Thank you so much. All right, so pancreatic cyst, everyone's favorite talk, except we see it every single week as an advanced endoscopist. And so the task that I have is to speak against my surgical colleagues and say, let us survey these cysts. And so how prevalent are they? So the older data suggested that the prevalence was around 15%, and we know that it increases with age. But modern data suggests that up to 34% of patients over the age of 70 will have cysts, and up to 50% almost over the age of 80 will have cysts. That's a large, alarming number of people, right? Our CT scans are getting better, our MRIs are getting better. What do we do about these cysts and the anxiety that comes with these cysts, right? Anything that has an association at all, even if limited, with pancreatic cancer causes anxiety for both patients and for physicians as well. So what we know is that the differential diagnosis of pancreatic cysts are quite wide. For asymptomatic pancreatic cysts, we have those that are non-neoplastic, like our pseudocysts that were recently talked about, all the way to those that can have cystic degenerations of solid neoplasms. How do we adequately risk stratify the different cysts that are possible, and how do we know that these cysts are what we think that they are? So every single talk, I always hold my breath because I'm concerned that the speaker will go through every single cyst type and the malignancy risk, but I assure you we will not do that because I assume that we have all read some part of that literature. So how do we manage mucinous pancreatic cysts? And the goal here is to convince you of surveillance. And what we know is that the diagnostic imaging is getting better by the year. And we have many different types of cysts: IPMNs, SCNs, MCNs, SPINs, and we have different imaging characteristics of these. So for example, a main duct IPMN with dilation of the entire main PD, a side branch IPMN here. Obviously, this is a very marked side branch IPMN coming off of the duct. An SCN in a young female patient here, an MCN in a patient who is female, a little bit older here in the tail of the pancreas, and kind of a bigger spin here, typically seen in young females and can have an internal hemorrhage component to it. But innately, if I gave you these 4 imaging studies, can you tell me which one goes to surgery? Which one, right? We can all guess. I think if I asked you half of you to raise your hand, is this a pseudocyst? Is this a spin? Is it an MCN? I think we would all have different answers. And some of it is not fair because a patient's journey is part of that scenario that gives us information of what these cysts are. But innately, imaging itself is not the best at telling us which type of cysts should go to surgery. We have different societal and consensus guidelines on how to manage these incidental pancreatic cysts. It feels like every single every single committee or professional group came out with their own clinical guideline. And so the first that we had was really the Sunday criteria in 2006, really putting a lot of emphasis on the cyst size, right? So unless the cyst is small, everything else either goes to EUS and surgery. The strength was that we were really sensitive at detecting malignancy, right? We were resecting a lot of these cysts, and the ones that were malignant, we got. But the limitation was that there was very poor specificity of malignancy, right? 23 to 31% of patients had malignancy, but that means that up to 70% of patients had resection for benign cysts. We then went to the Fukuoka criteria that gave us a little bit more optionality, right? Looking at not just cyst size alone, but things about the cyst and how it reacts to the pancreas and the duct. So we looked at enhanced mural walls, mural nodules, duct size, lymphadenopathy, distal pancreatic atrophy. Really, the only things that were meant to go straight to surgery were those with imaging studies that looked highly predictive of MCN's main duct IPMNs or branch duct IPMNs that had the solid components or those that were symptomatic. What we saw that was when we took the power away just from looking at the cyst size, but adding all these additional features, including clinical features and CT imaging features of the duct and the pancreas parenchyma around it, what we saw is that sensitivity dropped a little bit in really resecting out malignant disease, but we had an increase in specificity. So at least those that we took to surgery more likely had malignancy. The AGA then came out with their criteria looking at 3 different main high-risk imaging and became more palatable for the many physicians and general GI physicians that are looking at these CT imagings and MRI imagings and having to risk stratify patients. So really looking at the cyst size greater than 3 centimeters, main PD dilation greater than 5 millimeters, and a mural nodule. And if there were more than 2 high-risk features, you would proceed to EUS imaging, and if the FNA was negative, you would proceed to more MRI imaging every year, then every 2 years to stop at 5. And if there was more concerning risk factors, you would go for EUS or FNA with hope that you would get some positive cytology. And if you got positive cytology for malignancy, then you would proceed to surgery. And what we found here is with these AGA guidelines, our specificity and our sensitivity started to become more into a palatable mindset here. Sensitivity increases to around 83%, specificity to around 70%, and our positive predictive value and negative predictive value as such. But the questions really became, well, patients are living a long time, 5 years for a patient at the age of 70. When we have someone who looks like Raj Shah and Sachemani, they may live until 100, 120, like who knows? When do we stop? And so do you stop at 5 years, and do your patients actually feel comfortable stopping at 5 years if they're gonna live this long life? Right? So we had a study looking at initial surveillance of 5 years compared to extended surveillance of 5 years. And these are patients that had branch duct IPMNs, and you're looking at worrisome features or high risk features. And what they saw was there's an increased progression for some patients that if you stopped at the 5-year mark, you had around a 2.2% chance of having your high risk feature. But if you extended it another 5 years, that percentage actually went up for some patients, right? And then the incidence of having an advanced neoplasia went from 0.6 to 1%. These are very small percentages, but for a patient who's in that 0.6 to 1% of that population, that becomes important. So this study, CGH, makes us think, well, in some patients, maybe we don't stop at 5 years because the risk doesn't actually just peter off at 5 years. For some patients, it still continues to go up, even if it's at a low range in percentage. And so there becomes this concern about a personalized patient approach. Do we personalize when a physician gets a EUS referral? I think many of us interventionalists have gotten referrals for 6 millimeter pancreatic cyst. But you know what? The referring physician feels good about referring it to you and to have you make that decision. So however you set up your practice with your referrals, you either accept and you say, let's do an MRI imaging surveillance, or do you say, you know what? you're going to keep sending me these cysts and you won't stop sending it to me until I do this FNA to show you that this is okay. I'll just do it. And that becomes a more personalized clinical approach for you. How will EUS evolve and are there patient risk factors? So very briefly, I'll go through the role of EUS since that becomes so important. And the question is, are we really as good as we think or we hope that we are? And innately, there's a lot of strengths of EUS. We can identify intracystic mucin versus mural nodules, and we know that mural nodules are important. It's one of the 3 criteria for the AGA guidelines, so it must be important. We can determine the relationship of these cysts to the vasculature, the main duct surrounding structures if they need to go to surgery. There's high resolution evaluation of the parenchyma. Remember in the Fukuoka guidelines, atrophy is a concerning feature if you do see it. But the limitations are that alone an EUS visualization can be insufficient in determining cyst subtype and malignancy risk. And so if you don't need to do EUS, like if you have a woman with a large hemorrhagic cyst, don't take them to EUS. If you have a CT that shows a microcystic lesion in the tail with a stellate central scar, don't take them to EUS. We know that these are benign imaging qualities, but if they do go to EUS, what is our utility there? And so one of the big ones is being able to distinguish between benign mucin and a mural nodule. And here there are certain characteristics that we look for. So a mucin ball is hypoechoic in the center, hyperechoic rim. A lot of us like to kind of stick it with a little 25 gauge needle and see it bounce off the wall. And that gives us a little bit more comfort that this is a mucin ball versus a mural nodule, which is indeed pre-malignant. It's a solid component, which is either iso or hyperechoic without the smooth edges. And if you take a biopsy, we see tissue, we see a solid component. Next, we like to do EUS with cyst cytology. If you get a positive cyst cytology, it's 100%, almost 100% specific for malignancy. But the problem is how many of us get atypical cells when we do cyst cytology. The sensitivity of cytology to identify malignancy is quite low, 30 to 63%. And it's likely due to a lot of different pitfalls related to what a positive cytology can be, right? And so what we see is the ACG guidelines recommend that we do a cyst cytology to assess for high-grade dysplasia or pancreatic cancer when imaging alone is insufficient. But to get a positive cytology, it's very difficult. You can get insufficient aspiration. There's a differentiation between pathologic mucin versus GI contamination. There's variability in on-site cytopathology evaluation. So a lot of different things that can influence if cytology can be positive. Next, we go to CEA. It's by far thought to be our most accurate tumor marker, intracystic tumor marker for possible malignancy. Multiple studies have shown that the CEA level over 192 is kind of that threshold when being concerned for mucinous neoplasm versus not. But what we know is that a CEA threshold over 192 can misdiagnose up to 39% of MCNs. What we also know and what we hoped for was if we have a CEA level that's in the thousands, hopefully it tells us it's the most high risk IPMN subtype. What we know is that it's not true. So a gastric subtype can have a CEA level in the thousands, but the intestinal subtype, which is one of the more malignant subtypes of IPMNs, can have a CEA level that's quite equivocal in the 200s range. So it's not predictive of even the more high-risk IPMN subtypes as well. We then started to use amylase to tell us about whether it was pseudocyst versus a mucinous neoplasm. And amylase is great to tell us if this is pseudocyst, but it doesn't really differentiate between IPMN and MCNs. We then added glucose to it to be able to differentiate between mucinous and non-mucinous neoplasms, showing that a lab glucose level of less than 50 was highly sensitive and mildly specific for a mucinous cyst, and when in combination with a CEA level can give us high sensitivity for a mucinous neoplasm. But innately, what is the most important if we're trying to really predict if that cyst is going to have a malignant potential is to be able to biopsy tissue from the wall. But what we know is that malignancy is not homogeneous around the wall of the cyst, that it can be very patchy across the cyst wall. There's been multiple different ways to biopsy that cyst through the needle microforceps with the Moray forceps. Again, diagnostic accuracy quite good, tissue acquisition good, but you have to be able to biopsy exactly where that malignancy happens to be within that wall. And if you don't, then you may get a negative biopsy result. Same for cytologic brushing, scraping the cells off the cyst wall. Limitations there is that there was some mild association with pancreatitis, or using kind of a core needle if your cyst is within the pancreas parenchyma in order to get biopsies across the cyst wall itself. Again, bleeding can be an issue here, but able to get kind of diagnostic tissue sampling, again, if the cyst has parenchyma on the other side of your distal wall. We then went to molecular testing for cyst fluid analysis, KRAS and GNAS. But again, KRAS and GNAS are only helpful if the GNAS is positive. If not, then it's less helpful to tell us between IPMNs and MCNs. Lastly, just for the last minute, we'll talk about future directions using confocal laser microscopy, doing real-time histological evaluation of the cyst wall epithelium, being able to tell the difference between serous cyst adenomas, mucinous cystic neoplasm, neuroendocrine tumors, or pseudocyst based on confocal laser endomicroscopy. Again, there's an educational curve to being able to use confocal, but a really powerful tool that may be developed at some point in our algorithm. Being able to do contrast-enhanced EUS, this is especially helpful in patients with chronic pancreatitis that may have some cystic changes in their parenchyma, seeing if this is related to any sort of cancer or related to chronic pancreatitis. And lastly, we also have ability to treat cystic lesions, right? We talked about this yesterday a little bit about being able to inject either ethanol or paclitaxel to treat certain cystic lesions. Innately, the risk of cancer is very low for these cysts. If we looked at the US population and the SEER cancer statistics, overall risk of pancreatic cysts at the time of diagnosis is 0.01%. If we assume that the cyst is greater than 2 centimeters, the malignant risk at time of imaging is 0.21%. And if we assume a cyst of any size can harbor malignant potential, it's 0.25%. The risk potential is too low to consider surgery for every single patient. I'm sure my colleague will bring up that upfront surgical planning can be beneficial for a certain subtype of patients, and that is definitely a valid argument, but cannot be ubiquitously shown for all these patients that are going to show us with cysts, because risk of surgery itself with the morbidity and mortality is quite high compared to something like an appendectomy or cholecystectomy. So I'll end with just my last slide as to respect the time of my surgical colleague, is what is the outcome of interest in general? So it's what would benefit a patient with a pancreatic cyst that would prevent mortality from a cyst adenocarcinoma? And surgical series show that there's benefit to surgery, but these are in highly selective patients that are candidates for surgery with high risk lesions. It's not based on an average risk, patient profile. And so surgical series include patients with dysplasia, and many of these dysplastic cysts may never become cancer in the lifetime of that patient. And we can't consider all of these patients for surgery. There must be a significant survival benefit when considering a pancreatic surgery for a cyst. And so an analogous situation is kind of what we see for the algorithm of Barrett's esophagus. We don't take every Barrett's esophagus patient with dysplasia to surgery because esophagectomy is very morbid. The same thing happens here, is we shouldn't take every single patient with a pancreatic cyst that may have low-grade dysplasia to surgery because of the morbidity of what a pancreatic surgery can be. And so with that, a few take-home points is that it's very common. We have different ways to distinguish between mucinous, non-mucinous cysts and to increase our risk profile for malignancy. We're not great at it. We need better tools for sure. But we have so many other options than to consider every patient for surgery, and an individualized approach to the management of these cysts is key. And so with that, I thank you for your time, and I welcome my surgical colleague to come up.
Perfect. Thank you so much, Jen. We're now going to welcome one of our own surgeons here. He's one of our excellent surgical oncologists, Dr. Benedetto Mungo. He's going to be giving us the surgical perspective. So welcome.
Well, thank you so much for the kind introduction and for organizing this great course. So I won't flood you with numbers and statistics, because if we had good numbers and good statistics and good predictive tools, we wouldn't be having this debate. That's the point. What is my hope to give you at the end of this talk is the perspective of a surgeon and how we think about this and how we discuss candidacy with the patients. So we all have said how, 1 in 3 people pretty much, probably throughout their lifetime, will have pancreatic cyst. We talked about how we classify these, how we decide which ones are at risk, which ones are serious, which ones are mucinous. And I think that all the tools that we have developed, we have talked about, have done a pretty good job at telling us with near certainty which one is a mucinous cyst, right? And which one to focus on, which one is the one that could be a problem. The problem is, this is going to be thousands, millions of patients. And the overall risk of transformation is low, about 0.5 per year. So which ones are the right ones? We know which ones have high risk cysts. How do we choose the ones that we should operate, and why do we make that decision? There's many guidelines, as said before, from different societies at different time points. If we look at the European guidelines, and again, I won't really bore you to go through every single point, but most of the things we look at is presence of a mass, size over 4 or 3 centimeters, depending on the guidelines, and pancreatic duct size, main pancreatic duct size, and dilation. As guidelines have evolved through time, some of the surgical guidelines have become more aggressive. So if you go from the 2018 European guidelines to the 2024 Kyoto guidelines, you'll see that, in fact, the guidelines are pretty similar, but some of the size criteria come to a point in which, a more negligible growth should raise your attention, and so on. So the absolute indication for surgery between guidelines tend to be very, very similar. However, as guidelines have evolved through time, they tend to become more aggressive in cyst size and growth rate. So even with this, right, with all the predictive tools that we have, we know that guidelines per se are not a particularly predictive tool. Even people that we think are a slam dunk for surgery, truthfully have a risk of, having a good reason for us to do surgery, which is only, 50% to 80%. And when you start focusing on worrisome features instead of high risk stigmata, that number becomes even lower. If there is one thing I would like you to think about and bring on from this talk, is this. What should we do in the gray zone, right? What should we do? We all know what to do when we have a clear indication for surgery, and we all know what to do when clearly there's nothing we should do about a cyst. It's one of those million cysts that get sent to us. The patients we should be talking about and should be focused on are this, right? The gray zone patients, the ones that, maybe have a small IPMN with new onset diabetes and a mural nodule is not enhancing, or patients who have a slowly growing cyst you have been following for many, many years. They have a moderately dilated pancreatic duct that, goes up 1 millimeter per year, but, they are asymptomatic. They have no pancreatitis. These are the ones I think we can make a difference for. And these are the ones that we should be talking about and debate. So I think, and, as I'm like the surgeon in the room, that when cases are borderline, early surgical resection should be at least be considered. And in some patients, it's preferred. And this is the slide I was referencing for. This is the take-home message, right? All these guidelines, all these tools that we have are telling us, well, this cyst has some malignant potential, meaning it could be high-grade dysplasia or cancer. That's not the same, right? You don't want to take out, you shouldn't think, I think, in my opinion, that when you send a patient to the OR and you take out a pancreas cancer, that's a win. To me, that's a loss. That patient should have been resected before, because if you look at what the survival is, from someone who has high-grade dysplasia and someone who gets resected for a cancer, that's dramatically different. IPMN-derived cancers tend to be better behaved than cancers that grow through the Panin pathway. But still, they are pancreatic cancers, and they do what pancreatic cancers do, which is kill people. And so if we can resect people before we can get to them, that's, I think, the key of the discussion. That's the argument for early surgery, right? So these are two different groups of patients. The other thing to think about is that as many of us have taken these patients to the OR, they have done surveillance, they have resected them, these very often are not a focal problem. They are the symptom of a field defect across the pancreas. So patients who have cysts and who have cysts that have some high-risk criteria, some worrisome features, are actually much at higher risk than the general population to have another lesion, a separate lesion that could ultimately turn into a cancer, right? So when you resect this, you can see that there is a cancer that perhaps wasn't the cyst you were looking for. It's 2 centimeters towards the tail, and that's a separate cancer. So the other thing that my colleague also has brought up is that, of course, the lifespan is extending. You have these people that hopefully will live to 120, 130 years old in 40 years. And the risk of malignant transformation is dynamic, right? So you can't just assign someone to surveillance and, I think my slides just, there you go, sorry, they just froze here. Someone to surveillance and assume that the risk will be static over time, because that's just not true. We talked about the field defect, we talked about, accruing mutations. And so the longer you follow someone up, turns out the higher the risk of you finding something when you resect them is. And lastly, this is probably everyone's least favorite subject, but cost effectiveness is something that in modern healthcare we should think and talk about. And what I would say is that when you think, there's a conspicuous amount of literature that will point out that when you consider quality adjusted life years, right, which is defined as the strategy to maximize years of meaningful life you get at the lowest cost, usually this tends to favor surgery because surveillance, is expensive. It's not a huge difference, but it is a difference. And if you have to surveil people for decades at this point, at the end of the time when you do the balance, this will be a burden in the healthcare. But I point your attention to something. Even when you look at cost analysis, right, you see that before you could shape up a cost analysis that favors surveillance, you would have to have a specificity of guidelines, which is almost 70%, which we just don't have, right? And this is not even talking about high-grade dysplasia versus cancer. So early resection tends to decrease cost overall. The other thing that I think we don't stress enough, we just look at slides with numbers. And I can tell you as a surgeon, when I see these patients in my office, these are the 1-hour appointments. So the burden of anxiety is a real thing, right? And like the one element that doesn't appear in any guideline, but it's probably the most important in managing these people, is the patient's perception over this. Because this is already a topic that is confusing for physicians and for physicians that do this. And when you start talking to a patient and chaining 20, if I take this out, if you don't leak, if you live 5 years, if you live 20 years, like that just creates a huge anxiety of burden. And there's people that even if they don't strictly meet criteria, but you're worried enough that you're having that conversation, will be absolutely opposed to having any sort of surveillance. And then the other thing that I think a surgeon thinks as soon as we refer one of these patients is the perioperative risk for pancreatic surgery. I think where people get surgery matters and what surgery people get matters, right? I think that, if someone gets referred for a borderline cyst to a center that does, 2 or 3, 5 pancreatectomies a year, and you'd be shocked how many centers, even in the US, do so few a year, your mortality and morbidity numbers are much higher. As the volume of the surgeon increases, these numbers tend to become more benign. The other thing that is important, right, that we don't perhaps immediately think about when we just look at the numbers, cyst size, duct size, is which surgery do they need, right? Because a Whipple and a distal pancreatectomy have two risk profiles that are very, very, very different. And clearly, not only the immediate surgical mortality or risk of a distal pancreatectomy is much more palatable, and if this can be offered early in the course of someone you think has a high likelihood of having high-grade dysplasia, should be offered. A Whipple is a different discussion. I will admit that clearly, of all Whipples that you do for all patients, these are the ones that tend to do more poorly because they have soft pancreas, they have sometimes very tiny ducts. So these are the people that leak. These are the people that will give you a headache. So whenever we do offer this, we don't do it so lightly. We talked about how this builds up to a rationale that as guidelines evolve in time, surgical aggressiveness tend to be advocated. And so what do we do when we have a dubious case, right? What are some of the adjuncts we can use to help us make that discussion? How do we better stratify borderline cases? I did my fellowship in Pittsburgh, so I've seen hundreds of pancreas being sent, and there was a huge enthusiasm for molecular analysis at the time. I think that it's a good technique. It can add to the discussion. In my mind, like the benefit of advanced molecular techniques is not really to turn the decision point, making a decision from the scratch, right? Just because you have a molecular that says that the lesion is high risk, you shouldn't be taking it out. I think that the good use of molecular is that when you have a patient that both you and the patient are kind of on the verge of leaning one way or the other, molecular as a role. Like it can add to the decision making, it can ease the anxiety and it can help your willingness to go to surgery. But we have to keep in mind molecular tests are not perfect. If they were perfect, like we would just send them for everybody and just blindly go after them. This is a patient I recently resected, acellular cytology, pancreagen was indolent, small cyst, small integral growth, an MPD that was far from a centimeter. I think a lot of people in a patient who's over 70 with this criteria would advocate for resection. And this is when actually talking to the patient makes a difference. The patient was like, absolutely not. I want this thing out of my body right now. I was like, okay, we'll take it out. Turns out high-grade dysplasia in 5 different foci. So this is a humbling field. It stems good discussion, good talk. And truthfully, I think that more than debating, what I'm hoping to achieve today is, tell you where we come from when we advocate that some people can benefit from this and how you actually are hoping to use all the tools that you have in your quiver. So thank you so much for your attention, and I'll move on and we'll take some questions.
Not sure if that was a terrific presentation. It's really so nice to have our surgical colleagues with us because, like you said, to hear where you're coming from is so helpful. We'll go back to Dr. Fan to see if she has any reflections and kind of summarizing her point after having heard from our surgical colleague as well.
I think that was fantastic. I think this is less of a debate more than actually an agreement that in general, we have so much that needs to be done as a field, at least from the GI perspective, to increase the specificity, as you said. And it's very easy when a patient has a solid component and then those that are low risk. And the gray zone is where this multidisciplinary discussion is so key. And we hope that all of our fellows have the opportunity to go to an institution where you can actually risk stratify these in real time with your surgical and oncological colleagues at the same time. I think that there are patients, as you say, that definitely benefit from upfront surgery, but that requires a multidisciplinary discussion because the concern is and just like we don't no longer do colectomies for benign polyps, we hope to never take someone to surgery for a benign cyst. And when we do take them for surgery for a benign cyst, the hope is that was actually part of a discussion first, that multidisciplinary discussion that protects all of us, including the outcomes of the patient. So mostly I agree. I think your presentation was fantastic. I think we have a lot more to do in terms of the diagnostics of the field to increase the specificity, and that multidisciplinary discussion is key.
Yeah. Well, thank you so much. And likewise, great presentation. I do think as well that the main take-home message is multidisciplinary talk. And I would say that surveillance for some people is the right thing. And the enthusiasm, I think, of every surgeon in surveillance gets higher when you have the first one of these leak. Because when you have a patient that leaks and they're in the hospital for 3 months and they bleed and then the path comes back and it's low-grade dysplasia, they're like, why did I do this? You know, so I think that multidisciplinary discussion protects all us. And at the end of the day, we still don't have a set of guidelines that can give us a straight shot answer for the gray zone.
Perfect.
Um,
Go ahead.
Great talks. Excellent, both talks. I would like to start with a question of the surgeon. I mean, you showed data on mortality in super centers. I asked ChatGPT in the meantime, and the reality is different. So the mortality for surgery in Germany is 10% for Whipple, 10%. We kill 10% of our patients. In US, it's 4%. In Japan, it's 1%. This is what ChatGPT told me. So sorry for, for giving now this feedback. So that means despite it's somewhere between 1 to 10%, let's say 5%, we kill a lot of patients for benign lesions. On the other side, we cannot compare high-grade dysplasia in the pancreas with high-grade in Barrett. It's much easier to find these lesions. And my opinion is if we see a high-grade dysplasia, the majority, it's understage, it's a cancer. So this is a dilemma. What we do, and this may be in the future, we developed the AI tool for EOS to differentiate cysts. Maybe in the future, we can select cases with the help of AI to say, well, this is a candidate for surgery, putting data from EOS, clinical data, and so on together, and can survey patients. And another option could be not only survey patients, but also better treatment. We don't have really a good tool, ethanol injection, paclitaxel. I'm not convinced of this tool. There is a lot of work in this field, and many people will die, and we should find a solution. I don't have a solution.
I hope there's a fellow in the crowd that will take on Professor's task. There's a lot of work in the field for such a prevalent disease, for sure.
That was just such fantastic presentation. So thank you all for your contributions. I had a question for Sumit. When you talked about recurrent acute pancreatitis, one thing that was missing was how do you manage patients with pancreas divisum? And as you know, now we have level 1 evidence from the SHARP trial. If you want to just educate the trainees what the main conclusions were. And before you answer that, I'll just make one comment about, I think the field is, really going to change in these next few years with AI. You heard Carlos talk about the role of AI during EUS and how we can identify high-risk patients or lesions. I just want to caution everyone with regards to the use of biomarkers in general. I think, Ben, you brought that up. I think understanding the diagnostic characteristics, understanding the situations when you can have false positive results and how it can impact on patients' overall quality of life, anxiety, perception of the risk of progression is really important. So while it's easy to order these tests, it's important to understand what it does to our patients, because then they just want to get an EUS every single day or a CT every 2 days. So that was one comment that I wanted to make. And the third thing was I'd love for for Raj to comment on his POP versus SWAL study, because what we really need, guys, is randomized control trials in our field, right? So it's really nice to see that we're trying to address important questions that Eric, that you brought up. So I'll shut up and sit down and let you address this.
Sir, Raj, do you want to?
Put you a little bit on the, go ahead.
Well, we're just doing a randomized trial of 8 or 9 centers around the country, just looking at main pancreatic duct stones and whether they're best treated with pancreatoscopy up front or ESWL. Trial's ongoing. We only need about 30 more patients for anyone here in the audience that's from Colorado or the region. Thank you so much.
Great. We have a number of questions from the audience that we're going to try and get to. So the first one I'll direct to you, Eric. As chronic pancreatitis is driven both by an obstructive and a centrally mediated pathway, how do we incorporate this into decision-making for pancreatic ductal therapy?
This is a great question. I think it comes down to the fundamental of what you're treating with chronic pancreatitis. And I like to think that chronic pancreatitis is the disease itself is an onion, and you need to peel off certain layers of that onion. And I think it also always comes down to the expectations you set with these patients in your clinic. For the fellows in the room, you should be seeing these patients in clinic to discuss the kind of expectations up front. There's a handful of patients when we're in the era of direct access endoscopy, you want to just maximize how quick you can get patients into the room. But chronic pancreatitis, particularly with ductal disease, is someone you want to talk to up front. And so I like telling patients that, look, we have stones. This is something we could possibly take off that layer of the onion and see if it helps. But with it being a potential of this may not be the one thing that makes you feel 100% better. A lot of times patients do get some relief in saying, at least we've taken that off the table, and then we can move on to the next layer of the onion that might make your life better.
Perfect. I'm going to ask this next question to Sumit. Is THC considered in your patients with recurrent acute pancreatitis?
I honestly did not see it on the table. My understanding is THC is linked to acute pancreatitis, but it's not listed on the table. And I'm open to anybody who has.
Yeah. I'm going to just add real quickly, 100%. At first, again, I was with Sumit's kind of opinion, I just kind of had heard this, but in the age where THC consumption has gone up and more of my patients have stopped smoking, but having resubstituted that with THC instead, 100% I've seen an uptake in the disease of the gland.
It's interesting. I was here as a fellow in 2014 or 15, and Colorado is one of the few states that had legal marijuana at that time. And I remember how prevalent it seemed to me. Now Michigan has joined that list as well. So it's definitely been interesting. So thank you for bringing that question.
Yeah. And I think it's something that all of us will ask our patients sort of clinic, when we see them in clinic or prior to procedure, especially when we're evaluating for chronic pancreatitis and then recurrent acute pancreatitis. Okay, just so that we can keep on time and get through a number of these questions. When performing pancreatoscopy on a native papilla for a main duct IPMN, what sequence of wires would you use, i.e. first for cannulation, then for pancreatoscopy? So I can answer first, but then we can quickly go down to the panel. I normally prefer to use an 025 straight wire for my cannulations of the PD. And then if I'm going to do pancreatoscopy, I normally just float the wire. You obviously have the ability to use a long wire when you do your initial cannulation, but my preference is to use a short, straight 025 wire.
Short, I use an 025 Visi wire, and then I'll put the pancreatoscope over
Yep.
that.
So I actually approach pancreatoscopy first by doing cholangiogram and making sure I open up and get access to the bile duct. So I do start with just like your standard, sphinctertome, and then do whatever wire is accessible. Usually our unit uses angled VisiGlide wires often. And I will work on opening up the bile duct first so that I can create room for me to get into the pancreatic orifice. Once I'm in the pancreatic orifice, I will often, just for maintaining a price and not waste, I'll still use the same sphinctertome and angled wire. And then we still stay with the long system. So then I just I'll do a pancreatic sphincterotomy and then slide in the pancreatoscope thereafter.
And I guess if it's main duct and you're lucky enough to have a fish mouth, then you just shove the dome.
Oh yeah,
in.
that's always a nice case. If my goal is not biliary and just pancreatic, I'll use a 39 tome with a long 25 revolution wire, which is kind of my standard cannulation wire to get into the pancreatic duct, and then just do SPY right over that.
I'm using the angle type the VisiGlide 025, and insertion of the wire and the pancreatic EST, and additional balloon dilation I performed because sometimes it's a bit difficult to insert and from the papilla. So now, at that time we use a 6 millimeter in the diameter balloon dilation.
Thank you all. I think that just highlights how everyone has slightly different techniques, and that depending on what sort of device availability you have, there's many options. Okay, role of chemoablation in patients with IPMN. Maybe we can go down and see, who's doing. Jen, do you want to start?
Yeah, I mean, I don't do chemoablation for IPMNs. It's not widely available. There's like Indiana is a big center that does a lot of like paclitaxel gem for chemoablation. The initial studies look promising, but again, not widely available. I'm interested to see, and I think this was one of the questions, what our surgeons think about this approach? Because I would only honestly consider it in patients who are non-surgical candidates, but in
Sure. I think so that we don't just pick on Dr. Mungo, we can have Dr. Knoll maybe stand up and answer too how you guys feel about, cysts that we manage with RFA or chemoablation.
Yeah, completely agree with what you were just saying. Would be reserved really for that group that
It's not a surgical.
that's not surgical candidates. I
Yeah.
think that's a short and long from it. Yeah.
No, I would agree.
Yeah. Okay.
I would just add that, it sounds really easy just to do this, but you have to remember the unit kind of training, like bringing in a chemotherapy agent and have nurses handling that takes a lot of certification. This is a pretty large setup that you have to do. And I think that's been the biggest limiting factor of how much effort has to go just bringing these medications into this as well. So
We.
Yeah.
IPMNs. I mean, just think about it, right? I mean, if you give that patient pancreatitis who was not a surgical candidate, is that patient going to even tolerate an episode of severe pancreatitis related to chemoablation? Now, there is a randomized control trial that's comparing an alcohol-based versus non-alcohol-based ablation strategies for pancreatic cysts. So until we get those results, I think our approach is to try and avoid doing chemoablation.
Agreed.
So the one comment I'll make as well on chemoablation is we started doing it at our center as well. We use a non-alcohol based cocktail, and the CHARM trial also showed less than 0.01% risk of pancreatitis in that. So if you're going to get into it, as Sachin said, alcohol seems to be the one that causes the pancreatitis. In that trial, I think they had like 68% complete eradication. Our surgeons have been very supportive to it, but just like you all have said, that we have the same exact team perform the procedure every single time. I have the same nurse, same tech, same floating nurse for the procedure, and everyone's comfortable with the agent. The other piece about it is that it also comes down to not poor surgical candidates, but I think individuals that have these larger collections in the larger mucinous cystic neoplasms in the head of the pancreas, right? I mean, because that's a really life-altering outcome. If they don't want to undergo a Whipple procedure, they see the surgeon talks to them about it. They actually will send the patients to us to say, look, we think that this patient would probably benefit from chemoablation. So I think those are some of the things to also consider is where the cyst is located when you're looking at chemoablation.
Thanks.
In my mind, the problem with doing chemoablation in someone that would be a surgical candidate is the inability to know what you were ever dealing with in the first place, right? What if that lesion, was a cancer, went to the lymph nodes already? You just never know until they have lymph node metastasis. So that's why part of it is just like, if you know already surgery is off the table, then it won't really matter. But that's kind of how I would think about it.
Great. We have another question from the audience. For idiopathic pancreatitis without any high-risk features, should everyone greater than 40 years get outpatient EUS, or can we consider MRI, CT imaging to rule out malignancy? I understand EUS is superior, but keeping cost, availability, wait times in mind, can imaging alone be a reasonable approach? Amit, you want to?
This is a really great question. I think it takes into account a lot of the things that we're talking about, access, lead time, expense, sustainability. I think you really need to individualize it to the patient and what happened on the initial imaging. Keep in mind also, EUS isn't just to exclude malignancy. It's to get another good look at the bile duct and another good look at the gallbladder to make sure you're not missing sludge or small stones. So putting all of that together, I believe it would make sense to still do an EUS after an episode of pancreatitis that's otherwise unexplained in someone older than 40.
Perfect. Dr. Knoll, did you have a question?
No, and I just wanted to come back to that previous statement. I think, again, I sort of support the concern with making that call in somebody who at that time doesn't want to have surgery is very different to a patient who has got early cancer. The one is a preemptive, pre-cancerous condition where you're saying, look, let's go have morbid surgery for a presumed cancer. Very often in these cases, as soon as you start seeing transformation, your tumor markers go up, they change their mind and they say, okay, this is cancer, I'll take that risk. And I think that if you ablate in that group, you might not be able to offer them that sort of subsequent management. Yeah.
Thank you. Okay, we have a couple more questions, which we'll try and get through quickly so that we can give you guys time to get to the break and get all of your cards so that you can be at risk for the raffle. Do we know of any AI integration for confocal laser endomicroscopy since it needs a lot of training to be competent?
I don't. I hope, but I don't know.
Anyone else? Okay, go ahead.
If I can comment briefly on AI, keep in mind AI, we are actually, my group is developing tools for prediction of pancreatic cyst risk with AI. AI, unfortunately, is not magic, right? The way you develop a predictive tool with AI is that you feed it guidelines criteria, right? So basically you will, align a cyst to what a guideline says, but it won't tell you something you don't already know about that lesion. It just makes getting the answer that you want quicker and faster, but there's no, unfortunately, augmentation of the positive predictive value.
Great point. It looks like we have one more question. We're doing a good job of discussing cyst surveillance, but what are the panel's thoughts on future direction of pancreatic cancer screening to catch these patients even earlier? Eric, you want to weigh in?
I think it's just such a difficult thing to establish. Pancreatic disease is hard, and especially in the United States, because so many of patients with issues with pancreatic disease or pancreatitis are bouncing often between hospitals. So it's hard to establish a uniform guideline saying, well, it's just doing the studies to do it because these patients have gotten imaging so often with their disease process. So I think we're just really behind this, and it's going to take time to develop something like this.
We do have pancreatic screening protocols for high-risk pancreatic cancer patients, right? So CAPS Consortium, various papers stemming off the CAPS Consortium, if they have family members, 2 or more family members, if they have BRCA mutations. So we do have criteria for pancreatic cancer screening in high-risk individuals. That being said, there's no way that we can put anyone with a cyst into that category. There's just way too many millions of people until we develop a better sensitive algorithm to determine who will actually eventually get cancer. So we do have it based on other factors, but cysts not yet.
Perfect. What situations do you perform a celiac plexus block prior to stone removal? And I'm assuming this means prior to PD stone removal. Weigh in.
It depends if you believe in celiac plexus block. I mean, that's the big thing. I am a believer in it. I've seen it. I don't like doing them. I think this is what they're trying to ask is like, will you just try celiac plexus block up front before you start going down the road of stone removal? I leave it to the patient. I mean, it depends on what the situation is with the stone. Are they getting recurrent pancreatitis episodes, and that changes the calculus there. So if the etiology or if the stone is causing a problem, I would not go straight to a celiac plexus block and say, hey, we're just going to let this sit for a while, you know. But I would never do them at the same time as well, if anyone is asking. So I've seen some people ask me, well, why don't you just do that for pain, you know, while you know, to help them at the same time? It's like, no, I want to know if stone removal is actually helping. I don't want to put too many cooks in the kitchen. So,
Yeah, my opinion, most of the patient, the pain improved after the only a stent insertion. Oh, but then we remove the stones. If some patient remaining the pains even in after the stone removal, at that time that we refer to the anesthesiologist.
And I think that just sort of highlights that it's an individual approach sort of based on your, you know, the patient itself and sort of your assessment of what is really causing the pain.
sure.
Raj, go ahead.
Yeah, no, just these are all excellent points. I just add that for this question specific, I think if the stone is in the main pancreatic duct causing ductal obstruction,
Yeah.
upstream ductal dilatation, those are the ones you'd probably try to pursue
Remove the
if there's a
stone.
structural cause to try to go that route rather than a block.
Yeah, and I think you have to go back to what the symptom is. You know, is it just pain, or is it something that it's actually causing glandular inflammation and whatnot? And that's a different calculus, right? You know, if you're having sequela of a stone obstruction, you need to treat the underlying cause, correct? And so you can't just focus just on chronic pancreatitis, pain. So you have to really kind of think about, is there any other sequela that's going on?
Sure. Sachin.
I'll just make a point. I think Hero's point is excellent to see if it's the stone that's really causing the symptoms of abdominal pain, attacks of pancreatitis, and putting in a stent to see what the response is, which may guide your future management plans. I will say, though, that when you're placing a stent, what is important to assess is if you've actually got the stent beyond the stone or not. Sometimes just placing a stent distal or closer to the ampulla may not be enough, because patients may still continue to have pain, and you may still proceed with pancreatoscopy management of the stone, and then you realize that the patient does have response to your intervention.
Yeah.
That's just my anecdotal experience.
Very good point. So the beyond the stone, it is very important. Sometimes it's very difficult to pass this area because it's concomitant with pancreatic stricture. At that time that we cannot pass the guide wire at the region. At that time that we perform the ESPGS, pancreatic gastrostomy. So and after the creation of the ESCL, we perform the pancreatoscopy and crush the stone by laser. So maybe most of the case resulted such kind of procedure.
Agreed. Excellent. Okay. I think we're going to go to break now so that we can keep everything on time. Thank you for excellent lectures, a great debate, and awesome questions. So thank you, everyone.